Hemoglobin disorders, we'll start off with the sickle cell anemias. Sickle cell anemia occurs because there's one defect in an amino acid. There's a switch in an amino acid, it's at number 6 on the chain, and it causes the different chain to be formed, the way it folds on itself, and therefore that's the root of all the evil for sickle cell. What happens then is that hypoxic conditions will trigger sickling of the cells. They become deformed and trapped again in the spleen and are ineffective. In the newborn with sickle cell anemia, they will be asymptomatic. The reason is that they have fetal hemoglobin, which does the trick for them. However, as they get older and the fetal hemoglobin starts to go away and adult hemoglobin is being produced in large quantities, that's when they start having problems. So usually you don't see manifestations until about 2 to 4 months of age. The first manifestation is dactylitis. They start having swelling of the fingers, and these are painful episodes. By 6 months of age, many patients may have functional asplenia because they have infarcts in the spleen from all the ischemia that occurs. And of course that puts them at higher risk now for certain infections. The sickle cell crises are these acute, painful episodes, various triggers such as fever, hypoxia, other infections, or sometimes just spontaneously they'll have a sickle cell crisis, and all these cells start to sickle more and they have ischemic injuries. These will cause painful extremities. They can also have headaches. They can have what's known as chest syndrome. They can have strokes. All of these things can occur because of the sickled cells and the hypoxia. Very severe crises can lead to ischemic changes, and they can have, for example, avascular necrosis of the hip. They could have osteomyelitis. Remember, when we talk about osteomyelitis, we always mention Staph aureus, but in patients with sickle cell, salmonella becomes almost as common as Staph aureus. Patients will have splenic autoinfarction. These ischemic changes, basically the spleen just withers away, and it puts them at risk for infections with encapsulated organisms. They can have stroke, and they can have what's known as acute chest syndrome, where the hypoxia causes them to have pain, and they can have actually little infarcts there too. The pain causes them to not take deep breaths, which causes more hypoxia, which causes a worsening of this episode. And in males, they can have priapism with these acute ischemic attacks or crises. Again, the spleen pretty much auto infarcts and splenectomizes itself, and that puts them at higher risk for infections. And they are also at high risk for an entire aplastic crisis, particularly with parvovirus. So patients who have underlying hematologic disorders are at higher risk to have problems with parvovirus B19. In most children, that's a very benign disease. In children with underlying hematologic problems, they can have an aplastic crisis. Lab findings include an increased reticulocyte count because, again, the destruction is occurring in the periphery, and so the bone marrow tries to compensate. They might have anemia, but not a really marked anemia. You can see some target cells, and characteristic on the peripheral smear are Howell-Jolly bodies. However, the real diagnosis is going to be made on hemoglobin electrophoresis, and you need to know that for the exam. Here, the arrow is pointing at some of these Howell-Jolly bodies that you see in the red blood cell. You can also see these target cells. Look like a bullseye right there, and also this one. Again, the diagnosis is going to be made with hemoglobin electrophoresis. That is the best test. There is some prenatal screening, but again, especially for the exam, you better know hemoglobin electrophoresis. Treatment is to prevent the complications. You need to be aggressive with treating infections. If they have problems with the crises, it's good to have them hydrated. You need to transfuse them so that they do not get more hypoxic and cause more problems. you need to make sure that they're all immunized. Patients with sickle cell will receive the regular pneumococcal vaccine under 2 years of age, but after they turn 2, you will give them the 23-valent pneumococcal vaccine because they need broader coverage and protection. Penicillin prophylaxis is given starting at 2 months of age, again because they are susceptible to encapsulated organisms, and so they will receive penicillin to help prevent them from getting any diseases. Pain control is very important. Transfusion, again, some of these patients require transfusions more than others. If they're in a hypertransfusion protocol, they are at risk for iron overload. Some patients will need deferoxamine. And again, we also try to treat them with hydroxyurea, which increases hemoglobin F levels. The definitive treatment of sickle cell will be bone marrow transplantation. We're now going to discuss the thalassemias, and the major one is beta thalassemia major, or Cooley's anemia. Again, it is a defect in the globin chain, the alpha chain in this particular case. There will be an increase in hemoglobin F. Again, this will present around the 2nd month of life because you have the increased hemoglobin F, but these patients will have anemia, they will have hypersplenism, and they can have cardiac decompensation, basically almost like a high-output heart failure. Look for what's known as an expanded medullary space. These patients, the bone marrow, the body tries to use any available bone marrow to make more red blood cells, and so you will have some craniofacial anomalies because of that. Particularly, you'll have almost like a expansion of the maxillary spaces. They'll also describe the skull, which is not a normal place for the bone marrow to really expand and to provide red blood cells. It will expand, and it creates a particular appearance on X-ray. They call it the hair on end, or the hairbrush appearance. Patients are basically born with only hemoglobin F. They will develop a severe anemia. There will be no normal cells seen on a bone marrow, on a smear. There will be no normal cells. And the treatment for these patients will be, again, transfusions and splenectomy, and eventually bone marrow transplantation. But look for these patients to have a somewhat different appearance because of the expansion of the bone marrow cavities.